Welcome to the latest episode of NAMI New York State Perspectives. We have a very special episode today. I know that I say that a lot, but this one really isn't for two reasons. First, we have an incredible guest, Dr. Tom Insel, the former director of NIMH and author of the great new book, Healing Our Path from Mental Illness to Mental Health. So excited to have him. But we also have our new co-host, our new government affairs coordinator, Haley Amering. Haley, welcome.
Thank you, Matt. Thank you. It's a pleasure finally being on board. I know it's been a long time coming, but I couldn't be happier.
Well, as our viewers know, Haley's been a guest on the show a couple of times and always has a great, unique perspective that she offers. And we're really excited to incorporate her further into the program. And she'll be doing future interviews with us, which is really great. But this interview was actually recorded back in October for education conference that took place in November. It was such an interesting conversation because it combined so many of my passions, but central to Dr. Insel's message, which I think is so important, is that we need to look at the mental health movement as a social justice movement. And I know for Haley, who works in advocacy, I think that it's so important. And, what were some of your key takeaways from the conversation?
Oh my God, it's hard for me to even sum it up so concisely because there's so many of them. But one of the biggest ones, honestly, was how Dr. Insel really emphasized that we need to talk about discrimination, not just stigma. That was something that when I heard him say that in the episode, I actually had to pause just to really take it all in, because it is so important. It is a social justice movement. And because of that, I mean, if you're not talking about discrimination, it's hard to kind of connect the dots and really get to where we need to be. So accountability and transparency is huge. And if you stick around long enough in the episode, you will also hear a quote from the great Marshall Linehan too. So always have to pepper that in there.
Yes, but always a plug for Marshall Linehan and DBT when you're talking to Haley and I. And you're so right. And it really is a call to action. And the timing of this is so perfect that we're putting this interview out as we're in the midst of our advocacy session. And obviously, this year is very different. We have an incredible opportunity before us with the really historic budget proposal that Governor Hochul has made, and we really want to make sure that we incorporate everybody's advocacy voice into the message that we need to get this passed and make the promise that the governor put before us a reality. So it's such a good time to hear this message from Dr. Insel, to get us thinking it with our advocacy hats on and really change our movement and make it more of a social movement and a social justice movement. And of course, we are going to be having our advocacy day on March 15th. We'll be sending out some more information about that. Haley's created some great resources to help people tell their stories that we'll be sharing. So we look forward to having you as part of our social justice movement. Right, Haley?
All right.
All right. Thank you and enjoy the episode. We're so honored to be joined by our Leader of Mental Health Award winner for this year, Dr. Tom Insel, author of the incredible new book, Healing Our Path from Mental Illness to Mental Health. Dr. Insel, thank you for being with us. It's great to have you.
Thanks, Matt. It's a real pleasure. And in my apologies for not being there in person, but it's just getting more difficult to be able to travel. So I really appreciate your letting me join by video.
Oh, of course. We're so thrilled to have you and discuss the book, which again was just such a fascinating read. It validated a lot of my previous beliefs about mental health care and challenged some other things. So I'm really excited to jump into this conversation and talk about the book. So, it's interesting. At the beginning of the book, right at the start, you talk about how you were giving a presentation when you were the NIMH director about the progress that NIMH was making. And a father in the back of the room responded to you by saying, our house is on fire and you're telling us about the chemistry of the paint. This reminded me of an incident that happened while we were in the NIMH Outreach Partner Program during one of the meetings. I think it was actually your last one while you were director. And you facilitated this discussion among the partners about what we were seeing in the field and what we were experiencing. And that conversation kind of quickly went a little sideways when people really started talking about what the myriads of challenges they were facing and either accessing services or trying to provide services. And I think that visceral reaction that you saw both in the father and among the partners is really a byproduct on what you identify in the book as a crisis of care. Can you explain how you see this crisis?
Yeah, I don't quite remember that specific meeting, but it doesn't surprise me. And I think there's always been some frustration, which I share,
Mhm.
about NIH broadly, um, NIMH, NIDA, the NIAAA, the the research institutes, not being as responsive as one might hope to the urgency of the problem. And part of that is that science does take time. And part of it is that they're working with an army of academic investigators who probably are not often more interested in I should say they're more interested in studying the problem than solving it at times. At least it feels that way. And I think the third thing, which I never really understood when I was at NIH, which was for 30 years altogether, 13 years as director. And no one never asked the question, who's going to pay for this, or how much does it cost? And maybe that's okay. I mean, maybe that's good. When you're doing science, you want to really understand, you want to answer a question in a way that's really thoughtful and rigorous and not biased by cost. But healthcare is a business in the United States. And so the crisis of care that you're asking about was largely because people aren't paying for the things that we know are really working and really helpful. And so part of my own frustration and my sense that I had to leave NIH at some point, leave the academic environment, was to realize that the crisis had gotten so urgent, the house really was on fire, and that all the fantastic things we were doing were just not responding to the urgency of the moment, of the need. Uh, I still think that it's important to study the chemistry of the paint. I actually think that science is this massive source of hope for all of us. And the idea that we will discover better treatments, we'll understand more and get better care as a result is really, I still believe, essential for the field. My leaving was really partly because I just felt like we already had good stuff. Like, if you look back on the 30 or 40 years of what NIMH had been doing, there was extraordinary progress and things that were ready to implement and things that really could change the care system and give us much better outcomes. And we weren't doing them. So somebody needed to be blowing the trumpet on that one. Somebody needed to be saying, hey, enough already. Let's take what we know and make sure it's what we do. And that's what wasn't happening.
Oh, thank you for sharing that. And we're going to get back. I do want to talk about how we view research and research being hope. I'm really glad you said that, and talk about precision medicine in a second. But one of the things, again, that I just found so fascinating when we look at this crisis of care, and something that mental health advocates talk about a lot is no health without mental health. But I really like in the book how you took it a step further by saying no mental health, no justice. And this really was very enthusing. I was very enthused to read this because at NAMI New York State, we're constantly trying to frame our advocacy issues as social justice issues. So it was encouraging to see you validate that belief. Can you kind of explain, why you see this crisis of care as a social or as a justice issue as a whole?
Yeah, well, I didn't start there, right? I started just trying, and this is why I wrote the book. I was just trying to understand, like, what's wrong here? Why aren't we doing better? And it was a little weird because when I talked to a lot of providers, they were pretty upbeat about all the progress. But when you talk to families and you talk to patients, that's not what you hear, right? And I was just trying to understand where have we gone wrong? Why are we not actually meeting the needs of people? And you know, it started off I was thinking kind of incrementally that, okay, well, we need to build a better care system. So we need to have more providers. So, let's address the workforce, let's address access, let's address quality. And I spent a couple of years first working for Gavin Newsom here in California, and then actually just traveling around the world trying to look at better programs and better, where do people get better outcomes? Where is Camelot for mental health? And what started to strike me was that it's not just about the care system as we know it. And it was kind of a central, I mean, it was really kind of an epiphany for me. I never really thought about it. But it is the case that in America, when we talk about health, we start talking about healthcare. But if you're in the public health world, or if you're in like global health, you start to realize that healthcare itself explains maybe 10% of health outcomes. It's a really small fraction. It's not like what clinic you go to, or how many meds you're on, or what med you're on, or how many times you've been hospitalized, but it's like, where do you live? Who do you live with? How do you live? What do you live for? All these things that have to do with, some people call them social determinants. I call them moral determinants of health. But these are things that are really not what we would call healthcare today. And yet they are what determine health outcomes broadly, but mental health outcomes in particular. And so this idea started to finally sink in, which I guess a lot of other people had thought about a long time ago. I was just slow to get there. That this is more than just a healthcare crisis. This is actually, in some ways, the people with serious mental illness who are now homeless or incarcerated are kind of like the canaries in the coal mine. They are showing us how we're failing broadly as a society, because they are some of the people with the greatest needs, and they're getting some of the worst outcomes, even though we're sometimes spending a lot of money. But it's not working. And so the problem has to be put in a broader framework. It has to be thought about. Really, to me, it's a social justice issue involving housing and criminal justice and education and workforce, all this stuff. As I thought about that more, what really struck me was that that's the crisis, right? The crisis is that we have people with essentially an untreated brain disorder who, instead of treating them, we incarcerate them, we let them become homeless, we let them eat out of dumpsters, and we think that's okay. And so in the book, I finally come around to saying, like, how do, how is this okay for any of us? This is like the Jim Crow era of mental health care. I mean, we have done something truly egregious and by failing this population, and nobody seems to really be talking about it or quite aware of it. I mean, people complain about homelessness, but they're not understanding that you don't solve homelessness until you start to solve the problem of untreated serious mental illness. And so putting it back into this social justice frame as a way of saying, yeah, let's really take this on like a civil rights issue. Let's create a movement to build awareness. And NAMI is they're at the front of this. They really are, and have been for a long time. Because that movement's going to be led by families, and it's going to be led to some extent by people in recovery. But it ought to be led by all of us. We all need to really, we need to sort of come to terms with what we failed to do and make a commitment to begin to do it. It's not that different. I'm old enough to remember the early days of the civil rights movement. It feels a lot like that. And it's time for us to really get beyond talking about stigma and talk about discrimination. Let's put this in the terms that you need for a social justice movement.
I'm so glad you said that, and you're so correct. We couldn't agree with you more. It's interesting. It's not from, I think, our failure, not really from a lack of effort. It was interesting reading about Governor Newsom and him looking back at his time as mayor of San Francisco and spending money, but not spending it the correct way, and kind of coming to you for guidance for that. Because it drew an interesting parallel to a lot of what we're seeing in New York City right now with the homeless population and what Mayor Adams is trying to do there, and incorporate mental health services into it. So I think you're starting to see a shift of better ways to spend that funding and being more effective in it. But realizing too that these are social justice issues. We are failing people when there's no other disease state where instead of treating them, we lock them up and things like that. So it kind of bridges to another word that mental health advocates use a lot, which is parity. And obviously, there's no argument that parity, as far as access and coverage, is paramount. But You argue in the book that a contributing factor to this crisis of care is using a medical model approach to treat psychiatric diseases. Can you explain why this doesn't work, as well as what part of the medical model might work in treating psychiatric patients?
Yeah, it's a great question, Matt. And I have to, again, it's one of those things where I think a lot of other people got this years ago, and I don't know exactly why it took me so long, but it's partly because, I come out of that medical model as a physician. I tend to think about, like, why have we done so well in cancer, heart disease, many other areas, and not done as well, infectious diseases in particular, and not really been able to get the same kinds of results here. So, so I like the medical model. I mean, and the fact is, it's worked really well for so many areas of medicine. It just doesn't work here. It doesn't work for, a few reasons. There's a place where we need it and a place where we don't. I think where it doesn't work is to deal with all of those social determinant issues, which are so paramount, particularly for people with serious mental illness. So the system we have, which is not really a healthcare system, I call it a sick care system. It's entirely focused on crisis. So it's reactive. You wait until somebody is suicidal or they're gravely disabled, and then they're in the emergency room, and maybe they're an inpatient, and they cycle through. Maybe they're in jail. They go through what is essentially, it's like a hamster wheel without any real forward progress. And all of us know people in that who are caught up in that. And it doesn't have to be that way, right? So we know the things that actually get people off that cycle from the medical model cycle to what I'll call the recovery model cycle, which involves a whole bunch of things. You get peer support, ACT team, Clubhouse, supportive employment, supportive housing. There's like 6, 7 things we put together: family psychoeducation and support, and then really good medical care, not just psychiatric behavioral health care, but medical care. Sometimes you need dental care, podiatry, all this stuff. We know what needs to be done, and and again, partly because of NIMH, we had evidence about the effectiveness of all these things 30 years ago, 20 years ago for sure, and we're still not doing them. We're not paying for them. So we pay for the medical side. So we pay for that acute need, the crisis. Like you see this most strikingly with anorexia nervosa. I was just talking to a family who's it's like really struggling with a daughter who's probably not going to make it. But what was so stunning is that the insurance paid for her metabolic problem when she was acutely ill, but wouldn't pay for her therapy, the root cause, to actually treat her anorexia. It's just stunning. So the lack of parity is just so profound. It's just, and it is so much a part of of this fight, of this, what I'll call again an injustice, because we wouldn't accept that if it were true. If you said, well, in diabetes, we'll help you with your ketoacidosis, but we're not going to do anything to manage your illness long term. And that's the situation we're in here. Now, having said all that, there is a piece of the medical model which we do want to frame up and to make sure that people do get good medical care, and they deserve to get the same care that anybody else would get. I mean, the fact that we even have to say that is sort of stunning.
Yeah.
I just had a piece out in Psychiatric Times about it. I think it was out this week, about where we are with parity. And what's so striking is that the Ninth Circuit here in California has actually struck down the most important parity decision from 2020, sorry. We had sometimes called this Brown versus Board of Education. It was the Witt versus United decision, which finally said, guess what? United Health Services or Humana or any of these insurance companies, they don't get to decide what is medical necessity. The American Psychiatric Association, the American Society for Addiction Medicine, there are professional groups that know how to define medical necessity, and they put out criteria, and that's what everybody needs to use. And that was the Witt decision. That got overturned recently by the Ninth Circuit, and that's really gravely disturbing because it again says it's up to payers to decide what they want to pay for. Nobody can tell payers how they spend their money. Uh, and I get it, that might be fine in some areas of American life, but for healthcare, I
Yeah.
mean, really? You want the wolf to tend the sheep? I don't
Yeah.
know. That's a really good process for how to dispense high quality healthcare. So I'm concerned that we're still a long way from parity. We have the laws in California. We just passed yet another law, even more stringent. But getting enforcement is going to require, unfortunately, it's going to require litigation. And that's
Yeah.
just not happening enough.
I mean, it did happen here in New York. We were lucky where we did have our former attorney general sue a lot of the insurance companies who weren't adhering to parity, and then took the settlement money and invested back into mental health services, which was encouraging. But to your point, we shouldn't be having to have these legal fights at this point. We know what these diseases are. We want them treated like other diseases as parity. You wouldn't, well, so I guess sometimes insurance companies do. I mean, my wife does have a chronic disease and she's always jumping through hoops. So that's kind of the nature of the beast. But obviously, it when you're dealing with families that have mental illness or serious mental illness thrust upon them and they're looking to get care right away and get services for their loved one, obviously, the more hoops you have to jump through, the more challenging it becomes. And it's very
Yeah,
discouraging.
and Matt, it's even like the fundamental question. So my wife just had a hip replacement. Another reason why I don't want to travel right now.
Eh,
And it was stunning. Like they had a class for her before the surgery. The surgery was done in a beautiful outpatient facility with really good care. She came home the next day. Somebody showed up from physical therapy at her house, and they said, "Do you want me to come every day or every other day? What's going to work for you guys?" Like, you think if she had broken, instead of
mhm,
having the hip replaced, if she had had a psychotic break, you think we get any of that? I mean,
yeah.
it's just completely different standards. And even the fact that, as I said before, we pay for the acute care in mental health, but we don't pay for any of the rehab.
Right.
Like all that stuff I mentioned, like the Clubhouse and the peer support, you can't get that paid for by United or
Right.
by any of the commercial insurance. And now it's starting to get paid for by Medicaid, but even that is only true in North Carolina, maybe New York and
Mhm.
California and a few other states, Arizona. Most states aren't paying for fundamental basic rehab. Now, you break your leg,
Mhm.
you get 6 months of PT, you'll get the physical rehab you need. But the rehabilitative services, these psychosocial services, which we know are critical for recovery, that's left up to nonprofits. Um,
Yeah.
and I just imagine that for a moment. If you had to have nonprofits providing dialysis care or physical therapy, and they base their, support entirely on charity and philanthropy,
Mhm. Yeah.
that's just, nobody would
Right.
say that's okay.
Right. And
And
I
yet
think it,
that is the state of play.
right. It's so interesting. I think that goes back into the first question I asked where I talked about that partner meeting where things went sideways. And I think is exactly what you're talking about. It was all MHAs basically and NAMIs trying to provide the services they can under very challenging conditions. And again, it's nonprofits trying to deliver these
Yeah.
services under, we hear in New York what our providers are going through just the difficulty, keeping the lights on and the doors open and it is just a real struggle, and it's not like you said, it's
Yeah.
not balanced compared to other medical models.
So
Uh,
I just as a little bit of an aside on this, Matt, after the book was finished, I was trying to figure out what do I do with my life. And I thought, well, what this needs, as I said, was a kind of civil rights movement, social movement. And so I started a digital publication called Mindsite News to sort of be the voice of the movement and bring a lot of people together. And that was a good idea, I think. I'm not sure it's ultimately the answer. What I do think might be the answer for this country is I ended up actually joining with a couple of other people to establish a new company that is going to try to compel payers to support all those psychosocial services. So we actually took some people from Fountain House in New York, and I'm on the board. So it was, it's we didn't steal them. This was a friendly relationship. And we brought in some entrepreneurs from Silicon Valley and some phenomenal talent from lots of different places to prove out the idea that peer support, ACT teams, clubhouses, digital clubhouse, and a range of other psychosocial rehabilitative services for people with serious mental illness, that if one pays for those things, you'll save money. You'll save money on medical care, you'll save money on behavioral health care ultimately, because you won't have all the emergency room costs and the hospital costs.
Not to
And
mention
every
the
place we've looked,
incarceration and other costs that we know
all that
are
stuff.
byproducts, right?
Every place we've looked where people have tried this, in the VA, in Germany, in the UK, it's worked. It's worked beautifully. But there's been no real leadership around this in the United States. So we're really putting together now a public-private partnership, working with nonprofits, sharing profit with them, and trying to prove out the idea that actually it's good business as well as humane and effective to support recovery care as well as medical care. But you do need both. I mean, to be really clear, we don't want to throw out the medical model and say, oh yeah, these folks don't need healthcare. They do. They need very good, at parity, medical care, but they need something more.
Right. I mean, of course, you also talk in the book at length about the morbidity issues and the fact that, again, we're looking at people, especially with serious mental illness, living 20 to 30 years less than the general population. So obviously the medical model is very important to this, and you have to treat the whole person organically. So, to level set here for a second, because we've already thrown the word around a few times, recovery, and that's one of those words that mean different things to different people. If I were to ask 10 people in our audience today what recovery means, you'd probably get 10 different answers. So just so that we're all on the same page as we continue the conversation, how do you define recovery?
Yeah, that's a great, thanks for asking. It's a great question. The book's original name was Recovery, actually, and my editor said, it's going to end up on the 12-step shelf and nobody will buy it and nobody will read it. So she said, we need a different name, which is how we got to Healing for the name of the book.
Which I think is a more definitive, I think everyone knows what healing means, where I think it's a little more. I
hope so. Yeah. And maybe a little more compelling, I hope. But the definition, or how to think about recovery, is different, I think, in this domain than in the world of addiction. I was trying to actually answer the question of what is recovery when I was working on the book, and it was part of the thing I was exploring in all my travels. I was in Los Angeles talking to a really good street psychiatrist who works on Skid Row, who, by the way, is now part of Vana Health, my company. He's actually joined us. But I asked him, what do you think of, how do you define recovery? And he said, it's just the 3 Ps. And I thought, you got Prozac, you got Paxil. And he said, no. It's people, place, and purpose. That's it. If you can provide people, place, and purpose, that almost anybody can recover. And what he meant by that was that those people that he takes care of, people with serious mental illness, tend to be really isolated, socially isolated. They need social support. They need connection. We all need that. Like, we all need the 3 Ps, but these folks especially do to recover. And so, he was saying the great thing about a clubhouse, for instance, is they're not alone. And I love speaking of which, I can put in a plug for the new NAMI book by Ken Duckworth, You Are Not Alone. I have it here. Came in yesterday.
Dr. Duckworth presented last night about the book. So
all right, great. Awesome. It's really, we share the same agent, and we helped each other with the book. So in some ways, his book is really much more practical. It's like,
Right.
this is what you do with this problem. My book is more social justice,
Mm,
conceptual, a little bit more of a political statement, but I think the books go beautifully together.
yeah.
And Ken is quoted often in my book, and somebody who I really admire. But that social support, that first P, is critical. The idea that um, anyone who's going to recover has to have a decent place. So they have to have sanctuary, a safe place with decent food where they're not under threat. And then I think the one that we never talk about in healthcare is the third P, purpose. That it's I think really where we've missed the boat most of all is giving anyone with a serious mental illness a reason to recover. Give them something to care about, whether that's a job or a mission, like being a peer specialist, or whether it's just finding something, a religious cause, whatever that is, giving them something that that they can see as a purpose or as a
Right.
mission. So when I talk about recovery, I really think about the three Ps for the
Mm,
company, for Vana Health. That's our mantra,
yeah.
is making sure people get the three Ps at
Right.
scale.
Right. It's so important, and again, with people, the thing that I think both you and Dr. Duckworth do so well in both your books is put faces on people who, I mean, you talk, and we're going to discuss before later about the absence of affection for people with mental illness traditionally, and both of you in your book have kind of countered that by showing real faces of people living with mental illness and serious mental illness, and that they can succeed, showing someone like, Carlos Lararia, who you put in your book, and the incredible things that he's accomplished living with schizophrenia, and again, someone who has purpose. It's so important that, I think a lot of times you talked about clubhouses, and they're so important. They provide valuable services, but I think the good ones are the ones like we used to have one under our office at NAMI that had a little thrift shop where the people at the clubhouse actually worked at the thrift shop, and had valued their employment. I mean, it's interesting. You were talking about your wife and her hip replacement. I was in a car accident in May and had to take 10 weeks off of work. I had actually shattered my hip. I had to get reconstructed. And, part of that recovery period that was really tough for me was the lack of purpose. Just, being away from work for 10 weeks and being totally shut off. You don't, so much of our identity is through our work, and that's so much of our purpose. So I think, giving people with mental illness and serious mental illness that purpose, and having those sort of programs are just so important. It's more than just, like we say, giving them medicine and giving them, the P's being like Prozac and other medications, but actually giving them the purpose. I think that's the most important thing. And of course, the place too. I mean, you talk in the book about mental health housing programs. I think you just referenced the person in San Francisco. You talk about the book we started, the small one person house, and now it's like a whole big foundation. So I think those models are so important. So thank you for highlighting them. And I think it's things we often overlook, and sometimes even as families overlook the importance of purpose in our loved ones, and giving them that. So I'm so glad you discussed that. So one of the other things that we talk about a lot, and obviously you talk about it a lot in your book, is access and accessing services. We've kind of, already danced around that. Later today, actually, at the conference, we're going to be unveiling our report on mental health access. And, it's interesting. After doing all the research for the report, I really found it fascinating in your book where you say there are really a record number of psychiatric providers available. Before we talked about maybe not using money appropriately. We know the money's there. We talked about how when Governor Newsom was Mayor Newsom of San Francisco, he tried to invest in mental health programs that didn't work. We've seen that in New York with Thrive a little bit. But, so again, it's kind of like the money. We have the providers, yet accessing person-centered quality care is still a real challenge for so many. And, you share a law that I thought was so interesting, the 40-40-33 law, and how it explains how only about 5% of those who need quality care receive it, and recover as we define recovery. Can you kind of explain the 40-40-33, and to kind of explain how it explains why so few people are getting the care they actually need?
Yeah, I mean, as I said, part of the book was trying to figure out the things I couldn't understand, and one of them was that when I talked to individual providers, like therapists and psychiatrists, they would say, "Oh yeah, I'm doing well, and my people do well, and I'm doing better, and they're doing better than ever before. Well, we have better medicines, we have better therapies, and it's really great to see how much I'm helping people." And I feel that way in 2021 more than I did in 2001. Um, so I had that narrative alongside all the data from epidemiology that said between 2001 and 2021, the suicide rate had increased by 32%, but the rate of homelessness, the rate of incarceration, all that stuff was worse, not better. And I was trying to understand, like, how is that possible? How could the public health data, the population data be so dire? And yet, at an individual level, people feel like, hey, things are so much better. And I began to realize that the disconnect was really because most of the people who should and could be in care were not. And when you look at the population data from epidemiology, what you see is that about only about 40%, so about 40% of people are getting care. In the big study that NIMH supported, it was called the National Comorbidity Survey Replication, NCSR, that we did now, it's 2 decades ago. But it hasn't gotten any better as far as I can tell. They looked not just at how many people who should get care in the general population were in care. That's where that 40% number came from. But then they asked, like, what were they getting? What kind of care were they getting? And the stunning thing was that only about 40% were getting what they called even minimally adequate care. So care that had any scientific basis to it. And then when you look at that group, about a third get well, a third don't respond to the current treatments, and a third get somewhat better. So the idea was 40% are getting treatment, 40% of those getting adequate treatment, and about a third responding. So that's this 40, 40, 33 rule. And what it says is that those individuals I've been talking to, those therapists, those psychiatrists were saying, yeah, we're doing better. But it's if you take, you multiply zero point 0.4 by zero point 0.4 by zero point 0.3, you're down to like 0.05 or 0.06. So they're seeing 5 or 6% of the population, and they're doing better. They are, in fact, doing pretty well. But there's 95% of the population who they're not seeing. And that's the problem. That's really where we're at. So the answer, what we need to think about is how do you go from 40, 40, 33 to 80, 80, 33? And, back to your original question, Matt, the NIMH problem, NIMH is trying to go from 40, 40 to increase the 33 to 35 or 40, that's great, but it's really incremental. It's really marginal. The big pickup here is at the top of the funnel. It's getting to, instead of 40% of people in care, getting 80% of people in care. And that's all about not access per se, it's about engagement. And that's a very different process. Engagement means you have to do more than just provide access. You have to build trust. You have to actually have a relationship. And you have to be providing people with what they want, where they want it, when they want it, how they want it. We don't do that in modern mental health care, and but we can and we should, and we need to make that. We really need to make that the goal. Imagine if we could say that in the next 5 years in New York State, we wanted to go from 40, 40, 33 to 80, 80, 50 or 80, 60, 33. I think that would be, just you'd see just a remarkable difference in population health. But I don't even hear anybody talking about that or thinking that
Yeah.
way.
Yeah, and it's interesting because you kind of draw the line even further later in the book when I found this so fascinating when you say, for any of us seeking quality care, there are three major barriers beyond the issue of access. These three problems of training, integration, and accountability all have solutions. As with access, we know what to do, you say in the book. So what do we need to do, Dr. Insel?
Yeah. So we need to change the incentives, right? The system we have is the system we pay for. And where we need to go is to shift to a system that's very person-centered and family empowering. So, when people say, "Oh, like, who'd you write the book for?" I wrote it for families because they've really been completely left out. Actually, more than left out, they've often been blamed,
Right.
right? Blamed and shamed.
Mhm.
And yet, whenever, through the course of writing the book, I spent a lot of time with people who had recovered to just kind of get a sense of, how did you get the three P's? What was your journey? In every case, there was either a family or someone like a family who just had their back and who was there and never gave up. Always gave them hope. It's really stunning. Like,
Mhm.
that's just fundamental. So I think where we need to go, I mean, what we need to do here is to change the way we invest, to change the incentives, to say, and again, this is what Vana Health is all about. This
Mhm.
is what I'm working on every day now, is to figure out how do we make rehabilitative psychosocial care um, the the focus of what we do, and that includes all those things I mentioned: peers, families, ACT teams, good medical care, clubhouse, digital clubhouse, lots of things that can be done even remotely, because more and more people have access to the internet. Not everybody, but a lot of
Mhm.
people do. So we should be making that the focus with including both the medical model and this recovery model. Um, and we need that the word that you put in there, Matt, which I feel really strongly about, is we need to be held accountable. Like the thing that we have failed, I think, when we go back to like why do we have the crisis of care? For me, a huge piece of it was we never really set a goal. We never said this is the outcome we care about, and we're going to hold someone, maybe ourselves, accountable to reaching that outcome. And we can decide collectively what is that outcome? Is it reducing suicide in young people? Is it reducing incarceration for people with serious mental illness, or reducing homelessness? We could figure out. Maybe it's coming up with five measures of recovery and saying by 2030, instead of having 3% of people recover, we want that number to be 30%, and just like hammer away. I've been talking a lot recently to a colleague, Jim Kim, who he was he started Partners in Health with Paul Farmer, and the two of them together took on the problem of AIDS in Africa back in the late 90s. And it was very much like where we are with mental health. It was just like people said it's too complicated, it's too expensive, we'll never be able, like, let's just focus on prevention, let's focus on reducing stigma. That was literally the same conversation. And Jim and Paul said, no, we're not going to do that. We're going to treat people. And they set out a goal. They said, let's do 3 by 5, 3 million by 2005. Bill Clinton said, no way. Bill Gates said, never happen. And they were right. They didn't get to 3 million by 2005, but they did by 2006. And today we
Wow.
have 50 million people who've been treated for AIDS in Africa,
Wow.
who have survived. 50 million. And we're what, 15 years later. So it's doable if you set a goal and you hold people accountable and you make it time bound and you say, look, this is where we're going. This is what we have to do. It is a social justice problem, but it is a fixable problem. We can do this. We've done great things. We've reduced child poverty by 50% in America. We've improved literacy by threefold. We've done phenomenal things. We can do this. It's just taking, it's taking it on, making it a priority, setting a goal, and working towards that and holding ourselves accountable for reaching that goal.
Yeah, I love the vision you put out, and I think accountability is so important. I think you kind of said it earlier too. It's interesting when you're so in the weeds, so to speak, as a provider, and you think you're providing good services and good care, and you don't realize because it's all you know that maybe you're not, and that there is a different way. So I think that's so interesting. And of course, one of the most sad and unfortunate byproducts of this crisis of care that really kind of shows where we're at is the suicide rates. And you put it so powerfully in the book that you forget that, mental illness is a killer. We talked about comorbidities early, but, certainly the suicide rates, and they're so alarming here in America. And we see most causes of death decreasing, yet suicide is still skyrocketing, which is so scary. But balancing that, while we're seeing it increase here in America, suicide's decreasing in other countries around the world. So, as we look for different solutions and different options, what are other countries doing right that we're doing wrong?
Yeah, I don't know. I'm not sure there's one thing, but there's several interesting things that countries are doing differently. I've looked at this in the UK, which is they're really, and it's funny because they are very humble about this. They don't think they're doing that well, but they're actually doing a lot better than we are. And there are a couple of things they've done. One is that they've improved the quality of psychological treatments for people with depression. They rolled out this program called IAPT, Increasing Access to Psychological Therapies. And while they talk about it as increasing access, and it does, I mean, 500, well, it was 500,000. Actually, the number is closer to 1 million people a year now are getting access to psychological therapy for depression. But what they really did is it's not access, it's really very high quality, much improved quality. So when I said before that only 40% of people in the United States get the minimally adequate quality, well, actually in the UK, that number is like 90%. They have made sure there's, when we did Teach for America, they created a whole new workforce to provide cognitive behavior therapy and interpersonal therapy, sort of these evidence-based psychological treatments at scale, and they measured everything. So they have very clear metrics and they hold people accountable. So they do a great job relative to us in the way that they provide psychological treatment. Now, I can't say that that's the reason their suicide rate has gone down about 11% when ours has gone up about 30% in the same time frame. It's probably not just that, because it's, they have their suicide rate began to fall even before IAPT got to scale. However, it's still a good thing to do. I suspect, just like with other health outcomes, the suicide outcomes have less to do with the care system, in fact, but more to do with lots of things outside of care. So it's back to the 3 Ps. It's that people don't get that sense of connection, that sense of purpose. When I was at NIMH, I had all the directors have an advisory council that sort of tells them, what they need to hear. And as you mentioned, Matt, we have there are lots of groups. So there's the partners, and who are often NAMI or FH or MHA families. But this was the advisory group would tend to be people who are like experts in any part of the mental health world. And I had Marcia Linehan on my group, who's the founder of DBT and is a real expert. And she used to say, like, very clearly, hey, you want to reduce the suicide rate, the first thing you do is you don't hospitalize people when they're suicidal. That tells them they're hopeless. Second thing is, there are treatments, and she said DBT is actually pretty effective for reducing suicide. And third thing she said is they have to have a purpose, right? That's actually where that 3rd P came from. She once said to me that if you want to reduce suicide, give people a reason to live. And it's so obvious, and I had never really thought of it that way. But I think she was onto something, and that's probably has more to do with our, where we've ended up, and why it's been so hard to reduce the rate. We keep thinking the way to bring the rate down is to have better crisis services. Man, you should have good crisis services, but at the end of the day, that's more of that kind of model that really hasn't had the public health impact you'd like.
Yeah, and
Yeah.
hats off to Dr. Linehan. We're still like, speaking of the partnership program, I remember when we had her in Denver and we got to hear from her in person there, which was great. And I've leaned on a lot of her teachings. I mentioned my accident and when things were down, certainly leaning on her concept of radical acceptance. And I think that, in with suicide too, understanding, you might be struggling today, but 2 weeks from now, you might be better, and a month from now, you're better. So much to learn from Dr. Linehan, but that's a whole nother conversation. And we're almost out of time. So I want to kind of wrap up where we started almost. You know, when we began, we talk about all the factors in recovery and we get to value the importance of understanding the chemistry of the paint, as that father said, so to speak. Obviously, we talked about how NAMI New York State and our audience really values research as our hope for the future and just equate research with hope. So that's obviously a big piece of this puzzle. So can you talk about some of the advances in precision medicine and what gives you hope about that?
Yeah. There's I'm just working on a lecture on that for next week or the week after in Boston, when there's a whole conference on precision medicine. The idea here is to sort of taking a page from what has happened with breast cancer and lymphoma and generally in oncology, where it used to be that we would talk about the disease as like it's from its location, like breast cancer. Today, we don't even use those terms because we know that there are so many different forms of breast cancer defined by their molecular lesion. And that matters because they respond completely differently to treatments. So treatments that work for one form don't work at all for another. We're just not there for depression, psychosis, for even anxiety disorders. We have these broad diagnostic categories, and we don't know within them who has which subtype and which subtype responds best to which treatment. So precision medicine is a new hot area to say, let's figure that out. Let's figure out like how many forms of depression, like how many forms of breast cancer are there, and what is the best way to subtype. Some people call these biotypes, but it's not just biology. There's lots of other things. One of the things I'll do at the meeting is to show a kind of old paper, maybe it's 10, 15 years old, that shows that people who had lots of childhood adversity when they were growing up do not respond well to antidepressants, to SSRIs when they get depressed. There's a huge difference. It's a much bigger difference than what you get between any two antidepressants that you give. So there's a lot to put in here. Precision medicine then becomes not just kind of like finding a molecular lesion in mental health, but it's putting together data from biology, data from cognitive performance and how people think, and then we have ways of measuring that. Issues of their social um, situation and their social history, like childhood adversity, and adding in the symptoms and signs and what are they experiencing. It's kind of stunning to me that we still don't measure a lot of this. We don't measure sleep, which we know how to do. We don't measure activity or social engagement, all of which is easily taken off of a wearable. So all these things that we ought to be doing to make this a more precise science, which we could do today with the tools we've got. Still hasn't happened. It will. I have no doubt that in the next 5 years, this will become just kind of expected. You'll actually have, you'll understand somebody, not just whether somebody says they're sleeping better or not sleeping as well, but you'll actually have the data that tells you how many hours they're sleeping and what their sleep architecture looks like. And you'll actually know what their social engagement score looks like, and are they becoming socially isolated? And, are they active? Do they ever leave the house? All that stuff. We'll get there, but we're just not doing it yet.
So just to wrap up, kind of again where we started in this concept of needing to really create a social justice movement around mental health, I think it's important to note that research has a role in that. I remember a couple of years ago, I was doing something with an organization called the STAR Coalition, which its job is to promote clinical trial participation. And it was right after Larry Kramer, the AIDS activist, had passed away. And we kind of discussed he was the man who created a whole social justice movement around the need for research and research into AIDS. And I think there's so many, I mean, you mentioned the African AIDS project. There's just so many parallels there, and seeing how, the AIDS crisis in America went from the 80s to where we are now, where, as you say, it's no longer a killer, it's a manageable disease. And I think there's so much to learn from that, and the social movements there.
Can I jump in on that, Matt? Just this is really helpful, I think, for some of the families who are thinking about this. I was at a meeting recently with Bill Smith, who runs a group called Inseparable, which is really trying to lead that social movement for mental health in America. It's a new group formed about a year ago, 2 years ago, but Bill is not part of the mental health movement. He comes from the marriage equality movement. And he led that movement in the early 2000s. And he said an amazing thing. He said, for a long time, the marriage equality movement was about social justice and changing laws and asking for equal rights. And we got nowhere. And he said, at some point, we realized we don't need to be demanding equal rights. We need to be talking about love. That the marriage equality movement is about love. It's about allowing people to love each other. And that's when it took off. It took off at a pace that even he couldn't have imagined. And within 3 years from that moment, they were in the courts and succeeding. Stunning. And now he's in the mental health arena. And so that, demands the question. So how do you rebrand this? How do you redefine this? And he said, yeah, we can't just go out and shout for social justice. We have to frame this around hope. This is about hope, giving people hope. So Inseparable, which is his new group, and which I think is really going to be the point of the spear for this, for our social movement, I think has found the right message. I think that putting this message in terms of hope, and that's actually what I tried to do with the book, was to say, we know what to do. Let's do it. There's every reason to be hopeful that if we do the right thing, it will work. People will recover. We don't have to accept what we've been accepting. I think Bill is onto something. So I think this message of hope is the one that we really want people to put on their banners.
And that's such a good way to end the conversation. And again, thank you for not only highlighting the crisis of care and the depth of it. There was so much we didn't even get to discuss today, but to leave it with hope. I mean, it's so important that we not only highlight the problems, but you give us such a encouraging and hopeful roadmap for our future and where we need to go. So we just cannot thank you enough for your leadership on these issues and putting this forward and really inspiring us to what we need to do to contribute to the outcomes in the world that we want to see. So thank you so much, Dr. Insel. We can't thank you enough.
Matt, thanks so much for having me. It's a real pleasure to be part of this. Good luck.
Thank you.